Okay, and good morning. This is Commander Blaine, and uh, I'm gonna talk a little bit about rabies and operational medicine, infectious diseases. I wrote this lecture last year, about 9 months ago, actually, when I was in Djibouti as the director of medical services, and there's a lot of rabies in Africa. And then the last few slides on here, I'm going to talk about operational medicine, infectious diseases, and I added some slides on the World Health Organization neglected tropical diseases because that overlaps a lot with operational medicine, infectious disease that we see on various tours that we go on, and as well as humanitarian missions. So we can see a lot of these diseases. So um, anyway, yes, those are my two dogs at the left, and that's a rabid dog at the right. And the Let's see. So learning objectives. I'm not going to read every single slide here. I'm going to let everybody look at the slides, and I'm making all the slides available for download. I'll just I'm going to mention salient features that I think are important. I'm more interested in, what exactly do I do when the patient walks in the exam room, and how do I recognize this disease, and how do I treat it? But I'll mention a few interesting things about the various diseases. We're going to go over the cause, epidemiology, transmission, symptoms, clinical manifestations, prevention, treatment, prognosis of all these different diseases, including rabies. So the cause of rabies, and one reason I wrote this is I have personal experience with this. I run ultra marathons, and I'm very, very slow, but about 2 years ago, I got bit by a bat on my left knee. I didn't know it was a bat, or didn't think about it for a couple days, and I kept telling everybody a bird came out of nowhere and bit me, and of course it was not a bird. I had to go get all the shots for rabies, so that was my impetus to write this lecture. Besides the fact that I was in Africa, and I wanted to help people recognize this. So it's caused by a number of different neurotropic viruses. It's not just one virus. It's the Rhabdoviridae family list of viruses. They're bullet-shaped, single-stranded RNA viruses. I'm not going to go a whole lot into the exact structure of those. I want to go through these slides and get to the treatment and the recognition of this, and the post-exposure prophylaxis, which I think is very, very important. And the background of this I'll just mention briefly, and everybody can look at the slides later if you want to look at the exact pathophysiology and biochemistry of these viruses. But the mechanism is kind of ingenious. It's the virus will enters at the point of contact of the bat bite. If you're going to get bit by a bat, get bit far away from your brain or spinal cord, such as your knee or your foot, because it's going to take quite a few more days for that virus to spread through the nerve cells up to the nervous system. So the virus first enters the muscle cells at the site of infection. It replicates without a host immune response, which makes it very dangerous. It travels retrograde centrally up to the brain and spinal cord, about 50 to 100 millimeters per day along these peripheral nerves. It reaches the dorsal root ganglia of the spinal cord, and then starts to cause symptoms. The virus, once it gets up to the spinal cord and the brain, it then spreads centrifugally outward to, for example, the salivary glands, which is what causes that appearance of that wild dog and the salivary response. Epidemiology, it occurs in more than 150 countries and all continents except for Antarctica, mainly Asia and Africa. India is number one. It's usually stray dogs. They even have a syndrome. It's called puppy pregnancy syndrome. And it caused mass hysteria. You can look it up and you can Google it. And it has to do with lack of education and a lack of objective-based medicine and faith healers who treat this in India as opposed to doctors. Were 17,400 human deaths worldwide in 2015. 95% of human deaths were in Africa and Asia. 40% of deaths in children were under age 15. Dogs are the main source of rabies deaths, and that's usually not in the United States. That's usually Africa. So if you see a stray dog walking around, no matter what it looks like, do not pet it. That very first slide where you saw that cat, it was a cat that was hanging out at the coffee bean, the coffee shop at Camp Lemonnier in Djibouti, and I never petted it. I never pet the cat, but occasionally I'd go there and kind of lay down on a bench, and the stupid cat would jump up on my table, and my friend who was the veterinarian on the base. He never told me specifically because he knew I liked the cat, but the cat disappeared at some point. So I think, which is his job, to get rid of these animals if they're, not known on the base. Many countries, Australia and Japan, much of Western Europe, there's no rabies among dogs. Pacific Islands, many of the Pacific Islands have no rabies. India's number one again, 20,000 cases. China number two with 6,000 cases. Democratic Republic of Congo, 5,600 cases. They have a lot of laws protecting animals in India. I went with my wife to Mumbai, and there's just thousands and thousands of pigeons because they can't kill or control the birds. They won't for a government law that prohibits that. Switzerland, rabies was eliminated after scientists, I guess it's questionable practice, but what they did was they placed chicken heads laced with the vaccine in the Swiss Alps. Foxes ate them and immunized themselves. They're trying to do something similar in India right now, where they genetically alter mosquitoes to be susceptible to insecticides. And of course, that's a little bit controversial because you're genetically altering something, and it brings up questions on altering the genetics of anything, I guess. The Great Britain has been rabies-free since the beginning of the 20th century. It's protected by being an island, so it's much easier to control something when you have an island, and you can have quarantine procedures. Transmission, I hit up the infectious disease consultant at Ramstein in Germany, who is more or less in charge of Africa too, because that's where we get our consultants from for treating patients in Africa. And but my question was, where do dogs get rabies in the first place? I was writing this lecture, and I had all this data and all this information. And I couldn't quite figure out, okay, where did the dog get the rabies? And they get it from biting each other. So dogs fight, right? They scratch each other, they fight, they play with each other, and all you need is one rabid dog and fighting with another dog, and that's how they get it. It's let's see, host susceptibility to infection. So the size of the virus inoculum. So if you get a huge bite on your leg or something, and there's a lot of saliva involved, it's more likely to cause rabies. If you just get a little scratch or a little tiny bite, it's less likely to cause it. So the degree of innervation at the site of the bite, and again, this is not one virus. This is multiple different viruses in this family of viruses. So there might be more virulent strains of it. And so the virus has a variant that might, infect you. Host immunity and genetics is involved. Transmission. There's a lot of different animals that can transmit rabies. So bats, monkeys, raccoons, foxes, skunks, cattle, wolves, coyotes, dogs, cats, mongooses. We had mongooses underneath the housing units, the clues, containerized living units, which is, these big metal boxes we lived in Africa, and there were mongooses underneath these living units, and so you wonder if those things have rabies. So bears, domestic farm animals, groundhogs, weasels. It's almost never in hares, rabbits, chipmunks. So these animals probably do not have it. The infected animals usually very aggressive, attacks without provocation. Human-to-human transmission is very rare. There are some cases of transplanted corneas or organ transplants. Casual contact is not considered an exposure. And I'll talk more about that in the treatment part of this, and what you or the ER doctor has to look for. Sperm, vaginal secretion spread possible, but very rare. Clinical manifestations. So incubation period is between 1 to 3 months. It can be a long incubation period. When I got bit on my knee, I didn't have any symptoms at all. And I didn't have rabies, obviously, or I wouldn't be alive probably right now. But eventually my 13-year-old kept bugging me about, Dad, you got bit by a bat. And I go, what are you talking about? It wasn't a bat. Like the dumb doctor syndrome, right? Doctors don't diagnose yourself. And eventually my wife, she kept Googling the picture of the bite, and she got a whole bunch of pictures that looked exactly like the rabies bite. The two teeth, you can Google those, and then you can see what it looks like. So initial signs and symptoms: fever and headache. And then other signs and symptoms that can occur: partial paralysis, anxiety, insomnia, confusion. So these are neurological mental status types of symptoms. Abnormal behavior, paranoia, terror, hallucinations. Hydrophobia. This is a long historical disease. So hydrophobia is, fear of water. So people have throat spasms, and when it's induced by drinking water, and they become very, very fearful of drinking water because it induces these throat spasms. So that's where the hydrophobia term came, and a historical name for rabies is hydrophobia. So death is usually 2 to 10 days after the first symptoms. Survival is extremely rare if symptoms occur. So so hydrophobia is this fear of water, difficulty swallowing, panic. People cannot quench their thirst. Saliva production is greatly increased because of that centrifugal spread of the virus from this brain and spinal cord out to the salivary glands, and then the virus reproduces in the salivary glands. You'll see discussions of 2 types of rabies: furious rabies, which is 80%, which is the hydrophobia, and paralytic rabies, which is 20% of the time, which is loss of sensation and paralysis. So diagnosis, this is one of those things where if you diagnose this, the patient's 99.9% dead. The patient is probably not going to survive, and you need to take precautions for yourself, and anybody exposed needs to do this post-exposure prophylaxis, which I'm going to discuss. As everything all of us ever do in diagnosis, right? 90% of the time, maybe more, we all know the diagnosis from just a very careful history and physical exam. And history, when it comes to these rare infectious diseases that can affect our humanitarian missions in the Navy and operational medicine, the history has to take very careful account of epidemiological factors. So where were you? I get it. So my wife and I, we went to Seychelles, which is a country in Africa, which is about 400 miles off the coast of Somalia. And that was my 96-hour leave that my wife met me in Seychelles. And we basically sat on a beach the whole time we were there. But we drove around a little bit. but there's dogs. There's dogs running about. It's a beautiful country, but there's dogs running about. And so this is part of your history. You say, where were you? Where'd you travel recently? Did you see any dogs? Or other animals, of course, you're going to ask. You're going to ask about exposure to rabies or encephalitis, duration, progression of illness, laboratory tests you can get. But again, even though you have a laboratory test at some point, if you're lucky, it's too late if you diagnose it. So the differential diagnosis is huge. So anything that looks like encephalitis or myelitis. So when we say myelitis, we're talking about autonomic instability, dysphagia, hydrophobia, paresis, paresthesia with worsening course. So anything that we ever see in our clinic, doesn't matter whether it's a sore throat or rabies, anything that's worsening over a few days is, you really got to get your antennas up. And I personally, if anything is worsening, I see them back every 24 hours until they're getting better. Or I phone call sometimes, I'll do that. So this is a non-specific prodrome, 3 to 4 days. Symptoms longer than 3 weeks is it's probably not rabies. So if somebody's having these encephalitis type of symptoms or mental status symptoms I would say longer than 2 or 3 or 4 days, it's probably not rabies because the guy would have been dead. Improvement or no change in neurologic status. So if they're improving, it's not rabies. So diagnosis, autonomic dysfunction. So when we say autonomic dysfunction, we're talking about non-voluntary body functions, heart rate, blood pressure, sweating, etc. So sympathetic autonomic system, fight or flight, parasympathetic nervous system, rest and digest. So these are just symptoms you're going to see. Maybe orthostatic hypotension, palpitations, fainting, lightheadedness, exercise intolerance, and you got to take vital signs. For if people say, "Oh, my heart rate's going up," okay, well, you got to get an actual heart rate because people have palpitations sometimes, and that's obviously with a normal heart rate, and that obviously has nothing to do with their heart, maybe. Digestive symptoms: bloating, diarrhea, constipation, dysphagia. Urinary symptoms, difficulty starting urination, incontinence, sexual issues, erectile dysfunction, vaginal dryness, tremor, muscle weakness. So this is what the World Health Organization recommends for diagnosis. The fluorescent antibody test, or FAT, capital FAT, it's immunochemistry. If you're lucky, you got a PCR you can get. We were tremendously lucky at EMF Djibouti. Because even though we had 2 PCR machines next door at the Navy Medicine Research Unit, and we couldn't use those clinically, but I could run tests there all I want on their PCR machine. And we just couldn't document the chart. Oh, we walked over to the Navy Research and PCR shows this. I would put something vague in my note, even though I knew the diagnosis. But it was nice because it helped me with the diagnosis, obviously. Negri bodies. So this is what the pathologist is going to look for under the slide. That little round body right there is diagnostic for rabies. But again, it's only found in 80% of cases. There's light microscopy, which you're not going to get probably, but it's where you're at. Differential diagnosis, again, every source of encephalitis. So herpes viruses, enteroviruses, varicella, Coxsackie, echovirus, poliovirus, arboviruses like West Nile virus. There's some new encephalitis viruses coming out. So take a good history, season, geographic location, patient's age, travel history, exposure to bites, rodents, ticks, prevention. So animal control, right? Not our job, but in EMF Djibouti, we have a veterinarian on base, which I was extremely happy for, because when I knew I was getting stationed there, you guys know as well as I do, if you're a one-man shop, like you go to a small base, you're the dentist, you're the veterinarian, and you're the doctor, maybe. And then if something comes up in one of those fields that you're not board certified in, you get on the phone and you call Portsmouth or Navy Medical Center San Diego and say, "Can I please speak to the veterinarian?" And so he can walk you through something, which is what I've done many times. and that works fine. But I really don't want to be treating a whole bunch of dogs on base if I'm not the veterinarian. So animal control and vaccination programs, immunization of high risk people. So people who work with bats or and veterinarians or people who have high risk should maybe get this rabies prophylaxis, or at least the rabies vaccine. Immediate thorough wound washing is very, very important. So just soap and water for like 5 minutes or 10 minutes, and that decreases the viral load immediately. Education, and then we're going to talk a little bit about this post-exposure prophylaxis, which I think is the most important part of this lecture. But prevention, the rabies vaccine is available. It's made from killed rabies virus. It cannot cause rabies, right? We all get that question from people when they ask us about like, oh, can this vaccine cause the disease? And then we have to have careful conversations about no, it can't. It just prompts your immune system to provide a response. So in the United States, there was a dramatic drop in human deaths in the early 20th century from 100 to only 1 or 2 per year. And thank God I wasn't one of those 1 or 2. But the widespread vaccination of domestic dogs and cats is what helped. Development of human vaccines and immunoglobulin, and most deaths in the United States are from bats and not dogs. But we all know that people a lot of times don't vaccinate their dogs or cats, so that's a little bit dangerous. So high-risk people should be offered the vaccine. So veterinarians, animal handlers, rabies laboratory workers, spelunkers, people who play in caves, so rabies biologic production workers, people with frequent contact with rabies virus, so maybe like researchers, who deal with this. International travelers likely to come in contact with animals. So if you're, and we'll talk about this book I read about the Ebola, and if you're going to go looking for Ebola or be in areas where there might be these diseases, you probably should get a vaccine. So pre-exposure vaccine, 3 doses, day 0, 7, and 21 to 28 days. Periodic immunity testing if appropriate. I haven't done any post-exposure or post-vaccine immunologic testing. I might do that eventually, but I don't plan on being around bats anytime soon. The post-exposure prophylaxis. So this I think is the most important part of this lecture. So when does a patient require a post-exposure prophylaxis? So it varies. So all across the United States. So I'm going to talk about United States here, and if we're sitting in Africa, it's a little bit different story. And if you're the guy in EMF Djibouti and some guy walks in and says, I just got bit by a dog, you're probably going to treat immediately, but I personally would also get the infectious disease guy, or maybe just the ER doctor in Ramstein on the phone, or Portsmouth for that matter. It is super easy to reach these people on the phone. And I would just call that guy and say, here's what I got. I'm sitting in Camp Lemonnier, East Africa. What would you do? And even though you might know what to do, just load the boat, get 2 or 3 people on board saying, okay, we all agree this is what to do. But this is probably most likely what you're going to do. So simply touching a rabid animal, inanimate object or animal that had contact with a rabid animal does not constitute exposure. So that, for example, people always wonder, like, I got bit by a dog. The dog did not look rabid to me. What do I do? The ER doctor is probably not going to give you this post-exposure prophylaxis if the animal, did not have any signs or symptoms. If it was a provoked attack, so if you're teasing a dog and he bites you, doesn't matter whether you know the dog or not, you're probably not going to get the vaccine. So that's just one example. If it's an unprovoked attack and there's like saliva coming out of the dog's mouth and you don't know where the dog is, and there's a good chance you might get the prophylaxis. So people bitten by an animal are exposed to rabies. So you get 4 doses of the rabies vaccines, so days 0, 3, 7, and 14. and you get the rabies immunoglobulin on day 1 of the vaccine. So, and I'll just throw my little 2 cents here. It frickin' hurts. It's they take it's about, and it's not the vaccine. The actual vaccine and the immunoglobulin doesn't hurt. It's not the chemical. It's 15 cc's injected in 3 different areas around the bite. And it's a muscle. It's a muscle that shouldn't have 15 cc's of fluid in it, right? And and it's the volume. It's just the volume of that 15 cc's going inside of that muscle, and I've only cried a couple times in my life, and then that was an involuntary one right there. It really hurts, and you just bite your tooth or a magazine or something and just suck it up and get these things done. So the person previously who had a vaccine can get 2 doses of the rabies vaccine, and the rabies immunoglobulin is not needed. Now this is an interesting one, and I've had multiple people tell me this. So let's say you drank some alcohol and you fell asleep in your room, and you woke up and there was a bat sitting in the corner of your room. You're getting all this done because they don't know if the bat had rabies. It doesn't matter what the bat looks like. You're getting this whole thing done. You're getting 4 doses of the rabies. If you walk in and tell the ER doctor, I woke up and there was a bat in the corner of my room, you're getting 4 doses of rabies vaccine, and you're getting a rabies immunoglobulin on day 1 of the vaccine. So, so mentally disabled. So if you can't tell people, like if you walked in the room and you were awake the whole time, said, I saw the bat and I stepped out of the room, you're not getting this. If you fell asleep in that room, there's no way of telling if that bat bit you. So that's why you would be getting the vaccine. So they say that this post-exposure prophylaxis is 100% effective if little or no delay. So it's highly successful if it's begun within 6 days of the infection. And I think I did mine on day 3 or something like that. But treatment, there really is no treatment, but treatment after exposure, so wash the wound with soap and water, povidone, iodine, alcohol wash, and again, you get these 4 doses of the rabies vaccine and the 1 dose of the rabies immunoglobulin. It's really expensive. By the time you're said and done, this is a couple $1,000s of immunoglobulin and vaccine alone, and that doesn't include the $10,000 or $15,000 ER visit. So you hope you have insurance on this because it's terribly expensive, and it's 4 or 5 visits to the ER to get this done. And I'm in San Diego, and is where I'm stationed permanently, except for when I mobilize or do my ADTs or whatever. But it's hard to find a hospital that has all these rabies vaccines. So in other words, the local hospital near my house, Pomerado Hospital. So you have to call and say, do you have the rabies vaccine? Same thing if you get bit by a rattlesnake, right? You got to call and say, do you have this? So the local hospitals don't have this. They don't carry it. It's too expensive. And so if you know you're going to do this and talk about rabies or snake bites or anything else, you're probably going to be going to the university hospital or tertiary care hospital near your house. Prognosis, it's just about 100% fatal, 99% mortality if symptoms occur. And so that's the references. So that's rabies, and it's important. Now the fun part of the lecture. Rabies is interesting, but I'm going to talk about all the disgusting diseases that you can get in Africa, and or humanitarian missions, or any one of these austere sites that we sometimes have the fun to visit. Iraq, Afghanistan, etc. And I'm starting this off with a classification of living things because it's terribly fascinating what kind of things can cause diseases, right? They're not all bacteria and viruses. In my clinic, I always go, oh, there's only 2 things that cause disease, bacteria and viruses, sometimes fungus. There's some more stuff that cause disease that's really disgusting, and we saw it in Africa. So these protozoans, these protista, these one-celled animals, these amoebas, flagellates, ciliates, sporozoans. That's why I put this slide on here. I'm going back to college biology, thinking, what the heck is this protista? We all remember what it is probably, but anyway. I added some slides onto this neglected tropical diseases because I think it's terribly important from the standpoint of humanitarian missions that we do in the military. I got a chance to go to Puerto Rico and do a humanitarian mission, and you might see some of this stuff. And these are quote unquote end of the road diseases. So in other words, are you going to see it downtown San Juan next to the hotel? Yeah, probably not. But up in the hills of Puerto Rico, at people who live in a very impoverished area at the end of the road, that's where you're going to see this stuff. You will see it in these countries. So it affects the world's poorest people. The World Health Organization is trying to eradicate as many of these as possible right now. And about 1 billion people are affected with these neglected tropical diseases. And the way the World Health Organization and other countries are working to eliminate these neglected tropical diseases is mass drug administration. They're going to take an entire village and give them ivermectin, or whatever drug that's appropriate for whatever disease we're talking about. So basics, improving basic water, sanitation, waste disposal, hygiene. Drug companies are putting a lot of money into this. The U.S. aid, if you do these humanitarian missions or go to Africa, you'll hear a lot about U.S. aid. The U.S. gives them money, and they give us money to treat diseases. So it's a big collaboration in treating this. Bill and Melinda Gates Foundation, they're doing an awful lot of work on this. Japan International Cooperation Agency. So there's a lot of collaboration on this, which is great. So here's the neglected tropical diseases. I'm not going to read this slide to you because I'm going to go, these are my next few slides. But you can kind of glance at this. These are, I find this stuff terribly interesting because, besides making this lecture, and I wrote a newsletter when I was in Africa just for the medical staff and on the base. But before that, the last time I saw this stuff was second year in med school, right? Or maybe studying for my boards a tiny bit, but not much. So this stuff's really interesting, and you will see it occasionally. So it's nice to kind of review it. The malaria. I put a lot of hours into writing this PowerPoint, and it was terribly interesting who had malaria in the past. It's an incredibly important disease. So Abraham Lincoln, Ulysses Grant, all these many of the presidents, Jane Goodall, the primatologist, Davy Crockett, Sir Arthur Conan Doyle, who was a surgeon, by the way. So anyway, you can read that slide, but a lot of famous people had malaria. So the cause of malaria, and by the way, if you're the doc in Djibouti or Africa or Afghanistan, or you're going to take Malarone, if you can. And a little personal story here too. My liver enzymes went up just slightly, 200-300 range when I was taking the Malarone, because that's what it does, and in a small number of patients. And but you're going to take Malarone the entire time you're in these endemic areas. And I'll talk about that in a second here. But so single-celled protozoan parasite, so malaria. We tend to think, unless we study it a little bit, it's like, oh, it could be a virus, it could be a bacteria. No, it's an animal. It's a protozoan. It's actually an animal that causes malaria, a little one-celled animal. 219 million cases worldwide, 435,000 deaths in Africa, mostly children. 41% of the world's population live in areas where malaria is endemic. It's found in over 100 countries. Historically, the Civil War had 1,316,000 cases and 10,000 deaths. World War II, again, the U.S. Army, 490,000 cases, 300 deaths. Navy and Marine Corps, 130,000 cases, 90 deaths. Korean War had 390,000 cases, and the Vietnam War only had 78 deaths, but they had 40,000 cases. It's not necessarily the deaths that affects the military and our operational medicine readiness status. It's I've got a fever and I can't carry a rifle and I can't march today because I have a fever. I'm in bed for several weeks. That's the obvious operational medicine aspect to this. Symptoms: fever, fatigue, headache, vomiting, jaundice, seizures, coma, death. There's many different Plasmodium species. Only 4 are known to infect humans. And these are all Plasmodium. So Falciparum, Vivax, Ovale, and Malariae. The most dangerous is falciparum, and that's what we treat with that Malarone, which I'll talk about in a second. 80% of malaria infections and 90% of deaths are due to this falciparum. It can kill people in less than 24 hours. It usually doesn't, but it can do that. We had a couple cases in Africa where our senior enlisted and one or two other people, we didn't know what they had because we have a little rapid malaria test, which you see at the top there, top left, that picture, and it came up negative, but somebody was having a low-grade fever, and then we have access to a CBC. His blood count kept going lower, and we don't even play around with patients at a Role 2 EMF in Djibouti. We just chucked him on an airplane within a couple days and got him up to Ramstein. And I don't think they ever diagnosed what he might have had, but they because we just treat it automatically. It's obviously you're not going to wait to treat people before and to get a diagnosis if you don't have the diagnosis. You're going to treat the worst case possible. So VVAX and Ovale are interesting because they're less fatal, but they can sit in your liver, and you can get malaria 10 years after you were exposed. So they can sit in your liver and then come and get reactivated later. So kind of analogous to tuberculosis. So uncomplicated falciparum. These are some things you can get: altered level of consciousness, convulsions, acidosis, anemia, jaundice. Hyperparasitemia is defined as when they do a blood test and it's greater than 10% of your 10% is what they look at. Indications for hospitalization, so young children, immunocompromised, no acquired immunity. In the military, we're probably going to hospitalize you. If we're not going to let you go to work if we even have a slight suspicion of malaria. We're going to toss you in the hospital and just watch you carefully. So anti-malarial selection. So the treatment, so it's not just one treatment, right? It's the area of chloroquine sensitivity or resistance. So there's very updated maps about which areas are sensitive to chloroquine, for example. The local anti-malarial drug resistance you got to look at. There's government treatment guidelines for different countries, and because based upon sensitivity of the malaria to different drugs, and obviously drug availability and tolerability. So treatment, you're almost always going to use 2 agents if there's chloroquine resistance, which is extremely common. Or if you know you're in an area of chloroquine sensitivity, you can use the chloroquine monotherapy. And by the way, chloroquine is the one that gives you bad dreams. So be careful with people who may or may not have depression or suicidal ideation, and just kind of check on them, or have their battle buddy check on them when they're on chloroquine. And just something to keep in your back pocket, Malarone does not cause bad dreams. I had 2 or 3 or 4 different people over 9 months come into my clinic in EMF Djibouti saying, I got bad dreams. And I go, okay, because they think it's malaria medicine. I go, okay, what are you taking? And they go, well, they're on Malarone. And I go, well, in a respectful way, my answer is, well, that's nice, but Malarone is not causing your symptoms. So let's talk about your bad dreams, But primary prevention is personal protective measures, so minimize skin exposure, uniform sleeves, wear long pants, treat uniforms. All of our uniforms, by the way, if you get any BDU right now, or those type 3 NWs, they're automatically treated with permethrin. There's a limited number of washes, so if your uniform starts to fade, chuck it and go get new uniforms. Or ask for new uniforms, because it's treated with permethrin, and it probably doesn't work after a few washes, or a lot. It's quite a few washes. But apply DEET, sleep in permethrin treated bed nets. Secondary prevention is the Malarone or doxycycline. Primaquine, we take, by the way, so just a little pearl on the Primaquine. Primaquine is what treats the malaria when it gets into the liver. It kills the liver aspect of the malaria, and the Malarone treats the blood aspect of the malaria. So you're going to take Primaquine for a few days when you get back from your tour, and you cannot take Primaquine with G6PD. So that's that one. And I'm going to, now the rest of these slides, I tried to keep these to 1 slide each. And I got 20 minutes, and I'll try to I'm going to take the whole 20 minutes, but I'm going to give you 1 slide on every disgusting operational medicine infectious disease. I'm leaving COVID off of it because we're all got enough of COVID, and I left tuberculosis off of it. Other than that, I'm going to mention just one quick slide, and I'm not going to read every word on the slides. I'm just going to give you interesting aspects of all these different things. So Ebola, we had Ebola in Africa, and it was fairly close. It was in adjacent countries. A few kilometers away. So I was in charge of the Ebola emergency response on base, and thank God we never had somebody on base with Ebola, but we were ready and we had a plan drawn up. And so mortality 25 to 90%. There's 3 other hemorrhagic fever diseases. So there's Marburg, there's Crimean Congo, and there's Lassa fever. If you get a chance, read that book that I wrote, that I put on there, the Hot Zone, upper left-hand corner there. Great book. We had Ebola virus in Washington, D.C., in Reston, Virginia. You can read the book. It was not the one that affects humans, thank God, but we had it in the United States. Symptoms begin with a flu-like illness. That's a lot of these diseases: fatigue, fever, weakness, decreased appetite, and more severe symptoms: shortness of breath, chest pain, bleeding out of various areas in your body. Diagnosis, very, very, very difficult to make the diagnosis initially until it's too late. Recent history and physical exam. So travel to endemic areas, work history, exposure to wildlife. Non-specific labs, so low platelets, elevated liver enzymes, clotting tests, PT-PTT, for example. There are PCR, ELISA, or rapid antigen testing, and a lot of our Rural 2s and a lot of our small facilities, we have access to a lot of this stuff. You probably won't have PCR unless you're lucky to have that Navy research lab next to you. Prevention, hand washing, isolating patients, personal protective equipment, and there is an Ebola virus vaccine that we're not giving it to military though, but it is very effective. So MERS, Middle East Respiratory Syndrome. So this is a coronavirus. It's not COVID, obviously, but it is a coronavirus. And camels, we had a lot of camels in Djibouti, and they're walking around the streets, and when they die, they burn them in the burn pit on the base, and the base stinks up to high heaven on Friday nights. It's like a custom for locals to kiss the animals, that's one way that you can get this this virus. It's linked to travel to endemic areas, so it could be South Korea, Kenya. It's been seen in the United States, but people who who are in these countries and then travel back to the United States, they can bring it to the United States. Incubation period 5 to 6 days. So a lot of these upper respiratory symptoms are similar. It looks like COVID or common cold or anything else, right? Fever, chills, headache, non-productive cough, dyspnea, myalgias, runny nose, dizziness, that type of thing. Mortality rate 30 to 40%. So this is a dangerous virus. It's more dangerous than COVID. So screening patients with respiratory illness for travel to these areas is very important. And eating uncooked camel meat. I did not do it. I'm not very adventurous, but some of my friends and colleagues ate camel meat at the famous phrase, tastes like chicken. So brucellosis, again, I'm doing one slide on all this just to give you just a glance into this, some of these things, and then you can download the PowerPoint and you have this information. So there's a lot of different names for brucellosis. It's a bacterial disease, gram-negative, non-motile, rod-shaped coccobacillus. There's a picture of the bacteria, spread from animals, cows, dogs, pigs, goats, camels, fox, seals. You can get it from ingesting unpasteurized milk and soft cheeses from infected animals. Symptoms can last weeks to months. So there's a triad, classic triad, undulant fever, so up and down fevers. I've seen that, I don't know how many times in my career, where somebody just keeps walking in with a fever. I've seen it with COVID. I've treated a lot of COVID patients, most of them virtually, but I've seen people with COVID do this, have undulant fevers. They get fevers like, fever for 3 days, and then nothing for a week, and then all of a sudden fever for 3 more days, and then they do this for like a month or two. Sweating, it could be often a moldy smell, sometimes likened to wet hay, migratory arthralgias and myalgias. So, and then just some general symptoms, nausea, vomiting, decreased appetite, enlarged liver, spleen. Any funny fever going on, you really should palpate the liver and spleen. I know myself and a lot of us, we don't do that when we see a common cold, but you probably should do that. Diagnosis, blood culture, bone marrow cultures. There's an IgM antibody detection for serology. There's PCR if you can get it. The radiologist might get back to you, talk about Pedro Pon sign. If the radiologist tells you something on the report or verbally and you don't know what it is, call the guy on the phone and say, what is this? And then if and he may or may not say brucellosis. He's not going to write brucellosis in his radiology report, but if he puts something like a Pedro Pon sign, it's a specific radiological finding. Treatment, antibiotics, streptomycin plus doxycycline. It's easy to treat if you can catch it. So leishmaniasis, very easy to diagnose if you're looking for it. And basically anywhere you go where there's sand and sand flies and somebody comes up, to see that upper right-hand corner with that funny skin lesion there, just assume it's leishmaniasis and treat it. And I'm talking mainly about Iraq and Kuwait and places that you're going to play in the sand. So there's 700,000 to 1 million new cases, 26,500 to 65,000 deaths occur annually. It's extremely common. It's easy to treat too. Poverty, malnutrition, deforestation, lack of sanitation, urbanization. 3 forms: visceral, and there's some other names for it: Kala-Azar, black fever. You might have heard some of this. Cutaneous and mucocutaneous. So skin sores can erupt weeks to months after a person is bitten by the sandfly. There's a picture of that sandfly, by the way. Visceral leishmaniasis is the most serious and fatal. It's rare, but it's 95% of cases are fatal if left untreated. Fever, weight loss, enlargement of the spleen and liver, anemia, cutaneous leishmaniasis, which is the most common, which is that upper right-hand picture. The diagnosis, direct visualization on peripheral blood smear, a bone marrow, spleen, lymph node, or skin lesions. PCR is available in a lot of places, and ELISA, so there's serology also. Prevention, a lot of this prevention stuff I'm not going to mention over and over, but it's mosquitoes, right, or flies. So using DEET, using nets, repellents. So treatment, amphotericin B, there's miltefosine, topical, there's topical treatments, oral fluconazole is often used, if you think you got this, I would call the infectious disease doc, I would call the pharmacist and load the boat a little bit and kind of approach this in a group professional manner and treating this person. And trypanosomiasis, so this is a neglected tropical disease, several diseases caused by a flagellated protozoan parasite. So again, when I'm kind of fascinated by this protozoan stuff. So it's an animal, it's a one-celled animal, and it happens. So there's 2 types basically. There's human African trypanosomiasis, which is sleeping sickness, 30,000 people, 36 sub-Saharan African countries. And there's Chagas disease, which is American trypanosomiasis, 6.6 million people, mostly Mexico and Central and South America, 21,000 deaths, and it's caused by this kissing bug. And that's that upper right-hand corner, that kissing bug. I've seen these things in Southern California, these bugs. We don't have so much of the Chagas disease, but there are a few cases in the United States. And these are different diseases, different clinical manifestations. So the main one I'm talking about is the African here. The first stage is a hemolytic stage. You get a chancre or a skin lesion at the site of this I'm not sure how to pronounce this, but this specific fly bite, and you get swollen lymph nodes, blood in the urine, muscle joint aches, headaches, irritability. Later stages are neurological symptoms. So alterations in sleep, the sleeping sickness, confusion, slurred speech, seizures, difficulty walking, so ataxia. Physical exam, so look for swollen lymph nodes. If you get swollen lymph nodes for no reason, you're going to get a whole bunch of tests done, and you're probably going to talk to the ID doc. Direct visualization of this trypanosoma on a peripheral blood smear is possible, and there's serologic testing, and again, prevention, same thing for flies and mosquitoes. Treatment, pentamidine for the first stage, and then there is a medicine for second stages, which is the nifurtimox, and these other, and eflornithine, sorry. So again, the pharmacist is going to be talking to you, and the infectious disease doc is going to be talking to you on this. Schistosomiasis, so it's caused by a parasitic flatworm. There's a whole bunch of worms that causes diseases, and we saw this stuff in Africa. 85% of these cases are in Africa. Estimated 600 to 700 million people worldwide at risk. It's the most common parasitic infection on Earth. A lot of times we think of malaria as number one. Schistosomiasis is the most common. Malaria is number two. Is the most deadly of the neglected tropical diseases. So most people who get this have no symptoms, which those are the diseases that I hate, because if you have no symptoms, how am I supposed to diagnose it? So you can, but 12 hours of onset, you get a swimmer's itch, a rash at the point of entry. Later symptoms are fevers, myalgias, cough, diarrhea, chills, lymphadenopathy. And chronic disease, you can get seizures, paralysis, anemia, and the diagnosis is detection of these parasite eggs in the stool or urine. And prevention is snail control, actually, so that the transmission is through snails. And access to safe water, hygiene, improving sanitation. Treatment, very easy treatment. Praziquantel. Okay, so let's see, and I'm obviously not going to get through all these slides. I guess I need to make this a 2-hour lecture. I'm only going to get through 2 or 3 more of these slides, and then you're welcome to download the slides and look over them. And so ehrlichiosis, obligate intracellular bacteria that infects and kills white blood cells. Transmission is these ticks. It's a lone star and black-legged ticks. I put a picture of the tick on there. 2.3 million people annually. So time frame, spring and summer months. Symptoms are flu-like symptoms, headache, myalgias, arthralgias. And so later symptoms, if it goes on longer, it suppresses the immune system, and you get renal or hepatic failure, respiratory distress, and opportunistic nosocomial infections. Death is 3% of cases. Diagnosis, very difficult in the early treatment because those symptoms are vague. So ask about travel history. Fever of unknown origin is important to know. Excuse me. So lab diagnosis, you can see these Ehrlichiae microcolonies. I put a picture of that in the upper right-hand corner. Your pathologist can see these, and he might just call you and say, this is what I think it might be. Or differential diagnosis. PCR, serology is available. And again, prevention is the same, preventing tick bites. Treatment is very effective, doxycycline or rifampin. And cryptosporidiosis, we saw this in Africa with active duty folks. I'll just read a little bit about it, but it's just mild diarrhea, more or less, if in most cases. We had a guy, Special Forces guy, who was trying to win the hearts and minds or whatever, and eating dinner in various people's houses in various countries all over East Africa with his team, and he had a case of this, and I was able to diagnose it because we had PCR next door in the Navy research unit. So fecal oral route, it's a protozoan. Again, It's caused by an animal, one-celled animal. Sorry, you guys have gleaned that these little one-celled animals kind of scare me. Fecal oral route, feces in the streams, lakes, uncooked or cross-contaminated food. So he described some of the food he was eating in the living rooms of various people, and that's how he got it. He actually came in with 3 different diseases, which I'm not going to go into right now, but one of them was cryptosporidiosis. It's often asymptomatic. This guy had almost no symptoms. Just he had weeks of loose stool, not even diarrhea, but that was all he had. Excuse me. Cholera-like diarrhea. You can get malabsorption, hypovolemia, fever, abdominal pain. These are possible symptoms. You can get arthralgias and myalgias. And the diagnosis is microscopy, staining, or serology, and PCR if it's possible. We had PCR, which was great. I was able to diagnose this. And there's only one drug that treats this, which is the nitazoxanide. And but most of the time, even though I put that drug there, you don't have to treat it. You just give him loperamide if he's got diarrhea. You give him fluids, and that's it. Prevention. Disinfectants, and chlorine bleach, strangely enough, does not work to treat water supplies. And echinococciosis, and I'm only going to go for 1 or 2 more slides here. It's also called hyatid disease, or it's a cyst, and a hyatid, by the way, is a cyst containing watery fluid or tapeworm with a tapeworm larva inside. The cause is a tapeworm, and I put a picture of the tapeworm up there. If you look at that upper right-hand corner, that's kind of a scary picture, and I'll describe what's on that worm, which is how this aggressive little worm infects your intestine. So there's 2 types. There's cystic and alveolar. Transmission is accidental consumption of soil, water, or food contaminated by dog feces, usually, containing these tapeworm eggs. And so it's a 2 to 7 millimeter tapeworm found in dogs, sheep, cattle, goats, and pigs, and some other animals. Symptoms, you can have no symptoms for 10 years. And then if you start developing right upper quadrant pain and increased abdominal girth, it can be these liver cysts. Coughing up blood, chest pain. You can get lung findings because these cysts can go inside of the lung. Diagnosis is physical exam, as described above. Radiology, X-ray, CT, PET scan, ultrasound. They can identify these cysts and lab findings. Liver function tests, serology, IgG. Sometimes they'll do fine needle aspiration. Great, very easy treatment: albendazole or mebendazole, and prognosis is very good. And I think this will be my last slide, and the rest of it, we can, you can download, and I highly encourage you to download and look at the rest of the slides later. I spent a lot of time on them, and they're very interesting. You might lose sleep tonight reading the slides, but cystericosis is a tapeworm. It's caused by a tapeworm, and that picture right in the middle, it looks like it's out of a Dune novel. In fact, I'll bet you the authors of Dune use this little tapeworm as the for their book. But anyway, 4 large suckers and a rostellum or head containing 2 rows of hooks. So kind of scary. Epidemiology: 30 to 70% of epilepsy cases in endemic areas are caused by this cystericosis. It's roaming pigs. Areas that have roaming pigs, strangely enough, are at risk for this. Transmission is swallowing eggs and feces. So again, sanitation is how you prevent these. Wash your hands. Mechanism: eggs from the cysts infect the brain, spinal cord, muscles, eyes, and tissues. And so a couple myths that people sometimes hear. You get cystericosis by eating undercooked pork. Not possible. Only if there's larval cysts inside of the uncooked pork. So eating uncooked pork by itself that's not infected is not going to give you a tapeworm. So the Taenia tapeworm infection is not cystericosis, by the way. You can have the tapeworm infection and be fairly asymptomatic, and that's called teniasis. If the tapeworm gets in there and the cysts affect your tissues, then that's cysticercosis. Very, very common. 2.56 to 8.3 million cases a year. Africa, Asia, Latin America. The symptoms are dependent upon where you get the cysts. So brain and spinal cord, for example, there's a neurocysticercosis. Seizures, headaches, confusion, ataxia, cerebral edema, stroke, and death is possible. Prevention, washing your hands, good food handling, diagnosis, CT, MRI, serology. Treatment, again, albendazole or praziquantel kills the viable cysts. You got to be really, really careful. Don't just treat things like this without talking to the infectious disease doctor or somebody who's very, very knowledgeable, because if you treat this too fast, all those neurological symptoms can exacerbate and kill somebody. So there's very specific algorithms on how to treat this slowly, so you don't release all the chemicals and neurotoxins from these parasites. And so later treatment, sometimes they'll do ventricular shunts or neurosurgery, depending on if you get these cysts in the brain. So anyway, and I'm going to flip through the rest of the slides real quick just to mention what they are. So later slides, I was going to talk a little bit about salmonella, Bartonella, toxoplasmosis. Anthrax is interesting. Leptospirosis, caused by a bacteria. Chikungunya, I wanted to talk about that because I'll mention that real briefly. It's a virus. We actually, in the embassy in Djibouti, they had this rapid chikungunya test because it's so common. Chikungunya, about the only thing you need to know, the only really, really important thing, if somebody has muscle aches, severe muscle aches for weeks and weeks and months, get a chikungunya test because this is very common. The word chikungunya means deformed or bent over, and I should have put a picture of somebody who had this, but they're literally contorted. That's what chikungunya means, and it's due to the muscle aches. So Zika virus is on my slide set. Dengue, babesiosis, West Nile virus, and Buruli is a neglected tropical disease. Chromoblastomycosis, and dracunculiasis. It sounds dangerous, but it's a worm, guinea worm disease. And fasciolitis, leprosy is interesting. It's not gone yet. And lymphatic filariasis, again, worms. There's a lot of worms that cause diseases. And mycetoma is a fungus, actually. And onchocerciasis, and again, caused by flies, and it's again, little tiny worm. Soil transmitted helminths, worms. Trachoma, which is chlamydia, #1 cause of blindness in the world. Infectious disease cause of blindness in the world. And then my last slide was on yaws, which is same family as syphilis, and but you can look over some of the information there. Anyway, thank you very much. And you're everybody's more than welcome to send this slide set out to anybody. I just think it's terribly useful to humanitarian and operational medicine folks in the Navy and all branches of the military. I'm going to try to present this at the Operational Medicine Symposium in 12 months. If they have it, who knows, they might have us all do it virtually. But from giving this lecture, I'm obviously going to do that in a 2-hour time set instead of a 1 hour. But thank you very much for listening. And I very much enjoyed my 4 months as the senior medical officer at Navy Branch Health Clinic, Albany. And it was a pleasure to work with everybody. A lot of nice people you guys have. So I'm more than willing to take any questions. You can type the questions on the bottom right, or you can unmute yourself, and I think I can hear you. So I'm happy to answer any questions that anybody has. And let's see if and I'm not 100% sure if my speakers are working correctly. So if you are speaking, please. I think I'm going to have everybody type any questions in that bottom right area. If you can, please, because I think people may or may not be trying to ask a question, and for some reason I'm not hearing it. Okay, I don't see any questions, so I'm going to go ahead and sign off. And thank you all for listening to the lecture. And I put my email on that first slide. You can email me anytime you want. And again, you can download this slide set. And thank you.